Thank you so much. Okay, so we're going to go over frontline, unresectable. We'll talk about salvage, potential predictive biomarkers, and then we'll discuss at the very end resectable mesothelioma. So in this section, I'm just going to give you a very brief update on frontline systemic therapy as well as clinical trials and agents that are on the horizon. I think all of you know mesothelioma is a very tough disease to treat. Almost every chemo that's been known to man has been given to these patients. Largely, it's chemo-resistant with response rates less than 15%, and we know that combinations are better. The punchline is that the current standard of care in the U.S. is obviously cisplatin or carboplatin, if you must, with pemetrexed IV every 3 weeks. The phase 3 trial presented by Vogelzang in JCO back in 2003 got this FDA approved here in the United States. But again, it has had some criticism because cisplatin pemetrexed was only compared to cisplatin in this trial. And the bottom line was that the median OS was about 1 year. And we do see that that has held up through all the subsequent trials done to date compared to single-agent cisplatin, which was 9 months. Now, the main toxicities are obviously going to be neutropenia and anemia, and that's very consistent, but it's a very well-tolerated regimen. Now, in the unresectable setting, it's very appropriate to give carboplatin instead of cisplatin. If you're not going for curative intent, there's no real urgency to use cisplatin. The response rates are slightly less. You're probably looking about 25%, whereas with cisplatin, you tend to see more like the 30%. The Vogelzang study did report 40%. I don't see that in my practice. I usually see it more about 30% response rate. The overall survival is very similar if you use carboplatin. In Europe, they use something called raltetrexed instead of pemetrexed. We don't have that option here in the United States, but it certainly has shown equivalency. Now, across the board, all of the chemotherapy combinations are pretty much about the same. But again, we are not really advancing the field here, and so there definitely is a push to try to incorporate novel targeted agents into systemic chemotherapy in the frontline setting. Now, the problem with this is that whenever you've used targeted agents in the past, we've always given it as monotherapy in the salvage setting. And in that setting, our EGFR inhibitors and PDGFR inhibitors showed no significant response rates. And so because of that, they weren't really developed much further. We have looked a lot at the angiogenic pathway because mesothelioma is one of the highest secretors of VEGF and utilizes PDGFR and VEGFR pathways. And so although the monotherapy TKIs have never shown significant benefit in the salvage setting, combining them in different ways might be of use. And the reason I say that is because of this trial. If we look at the phase 2 study, this was cisgem plus bevacizumab versus cisgem alone. And then bevacizumab was done as maintenance until disease progression. Now, the bottom line to this trial was the overall survival was completely no different. So bevacizumab, when you give it to an unselected population, had no benefit whatsoever. But as we get into the biomarker section, which I remember now I put the slides in a different section, you're going to see that patients who have low serum VEGF secretion actually get benefit from the bevacizumab. So if we, instead of targeting the ligand, which is over-secreted in mesothelioma, but go after the receptor, we might see some more benefit. I'm going to show you a trial a little bit later that shows that proof of concept. Now, before I go any further, I do have to just touch bases with you on PDGFR. This is platelet-derived growth factor receptor. There may be an autocrine loop mechanism in mesothelioma with cell proliferation, and we also know that it affects the capillaries as well with the endothelial cells. And so there is a drug called cediranib. You may have heard a lot about it recently. It just showed at one of the European studies, conferences, that it showed progression-free and overall survival benefit in recurrent ovarian carcinoma and peritoneal carcinomas. So cediranib targets VEGFR 1, 2, and 3, as well as PDGFR. And so there has been a SWOG trial 0905, which is a phase 1/2 study of cisplatin pemetrexed with or without the cediranib. Now, in the phase 1 study, this was just presented at ASCO. The results were rather compelling. I'm just going to skip through the patient demographics and just go right to the data. So again, this was a phase 1 trial dose de-escalation study. There were 20 patients that were enrolled on here. There weren't any significant grade 4 or 5 effects. There was one patient who had a CNS disorder. We're not really sure it was caused by the drug. It wasn't the RPLS that you tend to associate. but it was an encephalitis, possibly meningitis, we're not sure. But of the two different doses, when you look at the efficacy results, the bottom line was we were able to increase progression-free survival to 13, 14 months. Now, if we look at the historical control compared to the Vogelzane study, the usual median progression-free survival for the frontline setting is 6 months. So this is more than doubling their progression-free survival. Now, overall survival was only advanced to about 16 months. Compared to the 12 months, this is certainly something we're looking at further. So we are currently in the randomized phase 2 trial. If you're a SWOG-affiliated institution, please do accrue patients to the randomized phase 2 for SWOG 0905. This is a high priority study for mesothelioma right now. Now, what about in the salvage setting for unresectable mesothelioma? This is just a quick update on the salvage therapies, but just briefly, I'm going to tell you our current standard of care is that we don't have one. There are no standard treatments for second, third line treatment for mesothelioma. Your choices are gemcitabine. You could do vinorelbine. I usually use that third line off protocol. You can do a combination of gemcitabine, vinorelbine, and if a patient has not had pemetrexed before, you want to give them pemetrexed second line or third line. Obviously, my favorite is clinical trials. Now, I'm briefly just going to touch on some of the upcoming novel agents which are showing some promise. There is, however, the verinostat trial I will tell you about. The bottom line to this study is one of the largest randomized trials ever done in mesothelioma, international site, 660 patients. You had to have at least 2 prior therapies, 1 or 2 prior therapies, and you got verinostat versus placebo. And the primary endpoint was overall survival. And unfortunately, the bottom line was it was totally negative. In the publication that's going to come out, they are going to report that the progression-free survival was better. The hazard ratio 0.75, the p-value is statistically significant. But I just want to call your attention to the fact that the median, this is actually supposed to be progression-free survival here, the median was 0.2 weeks benefit. When you look at overall survival, there was absolutely no difference whatsoever. So in mesothelioma, if you use a targeted agent in the salvage setting, if you don't have a predictive biomarker, it's probably not going to work. So that, unfortunately, was a very important lesson there. Now, what about some of the other agents that do have targets that are being looked at in mesothelioma? Well, there's SWOG 0722, which is looking at mTOR inhibitor everolimus at 10 milligrams a day. They have 55 patients on the study design. Reportedly, the publication should be coming out very soon. They actually did have some patients that had very significant responses on there. And again, the biomarker analysis is ongoing to determine whether or not those had high expression of mTOR or AKT. The other trial that I want to tell you about is the FAK inhibitors. A lot of times in mesothelioma, you get loss of NF2. It's seen in about 40 to 50% of patients with mesothelioma. When you get loss of the NF2 gene, you lose the protein Merlin, or it becomes inactive. Now, if you've got inactive Merlin, you have upregulation of FAK, or focal adhesion kinase inhibitor, kinase. And so there are inhibitors now to FAK that might be relevant. And so there's a maintenance trial currently by one of the companies that's being done. And then this was also a phase 1 trial that was done in mesothelioma as well as other solid tumors. Reportedly, the biomarker data is that patients who have low expression of Merlin or dysfunction of Merlin do get benefit from the FAK inhibitors. And so there's a couple of trials that are currently being designed with this predictive biomarker in mind. Now, what about immunotherapy? Mesothelioma doesn't seem to respond too great to targeted therapies and chemo, but what about using immunotherapy? Well, there is currently a large international trial ongoing with tremelimumab, which again is a CTLA-4 inhibitor. There was a Lancet Oncology paper based off of an Italian group that had 29 patients with previously treated mesothelioma on here. And the preliminary data did indicate that there were some patients that had some response with single-agent tremelimumab, and they also had significant duration of response. And so this is definitely a trial which we're asking people to consider supporting. It can be both peritoneal as well as pleural mesothelioma. They are randomized 2-to-1 to tremelimumab versus placebo. There are some stratification factors, but this is also a very high priority study, immunotherapy in mesothelioma. And they're looking for 180 patients. Okay, so what about potential predictive biomarkers? So obviously, in mesothelioma, it's a little bit different from non-small cell carcinoma. So for pemetrexed, everybody knows that if you have low thymidylate synthase expression, you're probably going to get a response to pemetrexed. If you've got high TS, then you won't. And also for cisplatin resistant, if you have high ERCC1, you're likely to have potential resistance. Well, when you look at the mesothelioma literature, and all of these are, again, retrospective analyses on trials that have already been conducted. Unfortunately, ERCC1 has no predictive benefit whatsoever for platinum. There was one trial that indicated maybe it's prognostic, but this is why we don't use this to screen for our patients with mesothelioma. Thymidylate synthase, however, is a different story. It was consistent with the non-small cell lung cancer literature. If you've got low TS, you respond to pemetrexed. Now, unfortunately, though, we do find that a lot of mesothelioma has low TS expression. And also, we don't have anything else in the frontline setting to give these patients. And so we haven't adapted using TS as a predictive biomarker to decide who gets pemetrexed or not in these patients. The other issue is tumor heterogeneity. And so generally we don't use these predictive biomarkers to decide treatment for our patients to date. Now remember I talked to you about bevacizumab in this phase 2 trial. Now we know that low serum VEGF expression in the serum definitely appears to be predictive of benefit to the bevacizumab therapy. And so the thought is, why don't we go ahead and target the receptor instead, and that might be a more effective strategy for these patients. We do also know that patients who have lower serum VEGF tend to have a better prognostic indication. So maybe they're not using the angiogenic pathway so much, so maybe their disease is a little bit more indolent. So this is certainly something in the serum that we are looking at. We are looking at it prospectively in some clinical trials to determine if this is something we can use to determine who gets anti-angiogenic treatment. Now, one of the other big developments in the field has been Drumline mutations. Now, I think this is kind of old news, but in Cappadocia, Turkey, there are some villages where there are death houses, where a lot of the patients, their families, over 50% of them will often get mesothelioma before the age of 50. And you never really wanted to marry into one of those families because of, the connotation of having a death house family. Now, we do subsequently know that maybe this is not necessarily an autosomal dominant inheritance gene that is very clear that you're going to get mesothelioma. There is some indication that maybe just that you get predisposed to mesothelioma if you're exposed to asbestos, because a lot of these families actually, it was identified that they built their homes out of the stones from the mountains which contained asbestos. So since moving all of them from those villages, we'll see if that inheritance pattern actually holds up. One of the other things that has come up has been the BAP1 gene. This is a BRCA1 associated protein 1. It's a tumor suppressor gene. If you have this germline mutation in your family, a lot of times your family members will either get uveal melanoma or mesothelioma. And so this is something that's under investigation right now. They may have a different natural history. They may be more susceptible to different treatments, and we're trying to define that right now. Okay, so what about resectable mesothelioma? So very quickly, there is currently no randomized phase 3 evidence that neoadjuvant chemotherapy is beneficial in mesothelioma. However, when we wrote the NCCN guidelines, we do recommend multimodality therapy, including neoadjuvant treatment with chemo or adjuvant treatment with chemo in these patients, because basically we don't have good options. And if you're going to try to go for surgical resection for these patients, you want to give them chemotherapy. Part of the problem is we don't have great systemic agents and we don't have predictive or prognostic biomarkers. And so this is a table of all the major trials that have been done to date in patients who had extrapleural pneumonectomy. Again, don't forget this has about an 8 to 18% 30-day mortality rate to do extrapleural pneumonectomy, and at 90 days, I believe it's 20% mortality rate, and it's a 76 morbidity rate. So you pick your patients very carefully if you're going to do this. And so all of these trials gave them neoadjuvant chemotherapy because it gives you time to determine if these patients are sensitive or not. Sensitive patients at our institution definitely go forward with resection. If they develop disease progression with chemo, very often we do not resect them because we know from these trials that we're not really curing these patients, even though we're giving them a highly morbid but curative intent resection. And so, again, these patients, you do have to be cautious with them. The patients who actually responded to the cisplatin pemetrexed were the ones that actually were far more likely to be cured at 5 years. Stable disease, it was touch and go, but then if they had disease progression, they had the worst prognostic outcomes in that trial. So we actually are doing novel therapies in the induction setting for mesothelioma. We will be presenting the final data of this very soon, but we actually gave neoadjuvant target therapies to try to elicit and identify predictive biomarkers. So we did 2 surgical stagings, the extended surgical staging here. We do a VATS thoracotomy in all our patients to rule out sarcomatoid histology because, again, you don't want to operate on sarcomatoid mesothelioma. We gave them 4 weeks of oral dasatinib therapy, which actually targets Src kinase, which we know is upregulated in mesothelioma. And then we did extrapolar pneumonectomy or pleurectomy decortication. We actually tried to account for tumor heterogeneity by doing paired tissue biopsies from multiple sites of the tumor. And then, of course, if they had a molecular response or a PET-CT response, they got 2 years of the dasatinib after 4 cycles of adjuvant chemotherapy and adjuvant radiation. And then certainly if they had a molecular response as well, they were entitled to get the 2 years of dasatinib therapy. Now, what we found out in the preliminary data was that the phosphorylated Src tyrosine 419 was a potential predictive pharmacodynamic marker to neoadjuvant dasatinib, showing a better progression-free survival for patients. And then when we looked at the prognostic value by mean level of baseline phosphorylated Src kinase, we did identify that these patients had a better prognosis. And so the ultimate data will come out, however, in the next few months as soon as I actually write the manuscript. But this is just some data demonstrating, and this you do get pleural effusions with dasatinib, and we did tap these, and these were all negative for cytology. But you can see that after only 4 weeks of patients who actually have high expression of Src kinase, they do get a response with the dasatinib. So our preliminary data is we did identify a subpopulation of patients. Again, targeted therapy should only be given to patients if you know that they have the molecular target. That's my firm belief. Otherwise, you're wasting their time. Certainly, there may be some prognostic and predictive value to this biomarker. And certainly, our infrastructures have to change in terms of neoadjuvant treatment in order to find something for this disease, because right now our current way of doing things hasn't been able to move the field forward very well. Now, one of the other studies I'm going to touch on is a vaccine trial. This was developed by Memorial Sloan Kettering, and it's 2WT1, which is Wilms tumor 1. This is usually something that you see in the fetus as well as in infants, but when you become an adult, you lose WT1 and all of your normal adult cells. Now, mesothelioma has high expression of WT1, and Memorial Sloan Kettering devised a 4-peptide vaccine that stimulates your CD4 T cells to attack any cells that express WT1. And they did do a pilot phase 1 trial that did show potential efficacy in not just leukemia, but also mesothelioma. So this is currently an adjuvant vaccine trial that Memorial Sloan Kettering and we are doing. Basically, you get the vaccine after you've had surgical resection, with or without neoadjuvant chemo or adjuvant chemo, and then radiation treatment. And again, you have to express WT1 on your tumor cells, and the goal here is to harness your own immune system and teach it to attack any microscopic tumor cells that might have WT1. And so we're looking definitely at immunogenetic responses on the blood to try to see who might potentially be more likely to respond to the vaccine. Okay, so in terms of clinical treatment right now off study for resectable mesothelioma, we do recommend that they get an extended surgical staging, so they get the laparoscopy where you check to make sure there's no transdiaphragmatic spread of the tumor through the diaphragm and that there's no cytology positive washings in the peritoneum. You also want to do a VATS thoracotomy and make sure that this is not a sarcomatoid tumor. We used to resect these sarcomatoid tumors, and by the 9th or 10th day that they're in-house, when they're ready to be discharged from the hospital, the tumor is back already. So we don't operate on sarcomatoid anymore. You can do extrapolar pneumonectomy for curative intent, but make sure your surgeon has a track record of doing this, because there's, again, 8% morbidity 30 days for us, 18% across the country, 90-day mortality is 20%. Pleurectomy decortication is very appropriate to do. We usually give neoadjuvant chemo. If they can't get an EPP, we will give them a pleurectomy decortication, and then we use IMRT to radiate all the high-risk areas, and then we put them on the vaccine trial. So this is definitely something you can consider. There's been some data showing that you can render these patients without evidence of disease with pleurectomy decortication and trimodality therapy. In the unresectable setting, current standard of care is cisplatin pemetrexed or carbopemetrexed. If you can't do platinum agents, you can give them pemetrexed alone. In the salvage setting, no standard of care. Please consider clinical trials that are biomarker specific, and then you can do gemcitabine or vinorelbine off protocol. And I think I will stop here. Thank you.